Good morning. Today we have a seminar on the topic neurocutaneous syndrome. Myself, Dr. Surabhi, and the session will be moderated by Dr. Soumya. So we'll be going through a brief introduction, the history, and the concept of rasopathies, and then we'll go on to the individual syndromes. So coming to the introduction, so neurocutaneous syndromes are a broad group of congenital disorders. They have a diverse genetic, clinical, and pathological features, and they share common developmental lesions of the skin and the nervous system. And most of these disorders are single gene disorders, and the main inheritance pattern is autosomal dominant inheritance, but some of the syndromes are autosomal recessive and X-linked. Coming to the history, so it was in 1920 that a Dutch ophthalmologist, Sir van der Hoop, he observed similar type of retinal lesions in three different syndromes, that is tuberous sclerosis, neurofibromatosis, and von Hippel-Lindau disease. And so he coined the term phaikoma. In Greek, it means lens shape. So, and he brought in the concept of phakomatosis, and initially, it involved these three clinical entities, that is tuberous sclerosis, neurofibromatosis, and von Hippel-Lindau disease. And then later, more and more syndromes came, and so which did not have the typical retinal lesions. So the term neurocutaneous syndromes was introduced. It was in 1931 by Yakovlev and Guthrie, and they described it as congenital malformations affecting more or less electively the ectodermal structures. But later, many more diseases, more than 50 more diseases have been included. And then it's not only ectoderm, but structures from mesodermal and endodermal origin are also involved in these syndromes. And coming to the concept of rasopathies, so several of these neurocutaneous syndromes are now categorized as rasopathies. So they are a group of related disorders, and they are caused by mutations in genes that regulate this particular pathway, that is RAS MAPK, mitogen activated protein kinase pathway. So I'm not going to explain the pathway, which is out of the scope of the topic, but this pathway is required for the normal cell growth, proliferation, and normal senescence and apoptosis of the cells. So, it contains many tumor suppressor genes, like the NF1 gene, like the VHL gene. So when they're mutated, it causes an abnormal activation of the RAS-MAPK pathway, causing abnormal cell proliferation, growth, and reduce apoptosis. So because of the activation of this pathway, many hematomas and this excessive proliferation of the melanocyte, which causes these typical lesions, they are formed. And the important thing is that these rasopathies can have overlap, like lesions in neurofibromatosis can overlap with other syndromes like that. And it not only include the neurocutaneous syndromes alone, they involve other syndrome also, like the typical Noonan syndrome and the Costello syndrome, Cowden syndrome. But the neurocutaneous disorders which are included in this rasopathies are neurofibromatosis type 1, Legius syndrome, Noonan syndrome with multiple lendigines, and capillary malformation, AV malformation syndrome. So in this syndrome, the AV malformations are formed in different parts of the body, like the brain, JT, lungs, etc. And then tuberous sclerosis. So we will come into these syndromes. So coming to the first syndrome, that is neurofibromatosis type 1. This is the most common neurocutaneous syndrome, and it is also known as von Recklinghausen's disease, and it is autosomal dominant. It is caused by germline mutation in NF1 gene. And so this NF1 gene is a tumor suppressor gene, and it is on chromosome 17q11. And so it affects 1 in 3,000 to 4,000 individuals worldwide. And the mutation rate is one of the highest in the human genome. And so 50% of the mutation can be de novo mutations. So this tumor suppressor gene, it encodes a protein called neurofibromatosis. So it is a negative regulator of this RAS pathway. So when this is mutated, there is overactivation of RAS leading to overactivation in the mTOR and the semi-PK pathway, causing excessive growth and proliferation. So now let's see the clinical features. So in the skin, we get the typical café au lait spots. They are macular, hyperpigmented lesions, as we can see, and they appear in the first few months of the life. And this is due to the proliferation of the melanocyte. And then we have the freckling that is typically seen in the axilla and the groin area. And in adults, it can also be seen in the neck as well as under the breast area. And so typically it is seen at around 5 to 8 years. And this sign is also known as Crowley sign. So next, we will go into the neurofibromas, which are benign soft tissue tumors of Schwann cell origin that arise on the peripheral nerves. So it can be cutaneous, subcutaneous, and plexiform. So the cutaneous fibromas, they are mostly asymptomatic. Sometimes they'll have some itching, and they start to appear at around puberty, like late teens. But this plexiform neurofibroma, the difference is that this cutaneous will be located in the skin, epidermis, dermis, and subcutaneous area. But this plexiform, they interdigitate with the normal tissue, and they infiltrate widely and deeply. So they are present from the birth itself. And so here we can see plexiform neurofibroma. So they are found in around 30% of the individuals, and they arise from they arise from the bundles of nerve vessels or nerve plexus. And it can be external as well as internal neurofibromas. And they infiltrate into the adjacent tissue, and they typically cause cosmetic disfigurement and also compression onto the local tissues, causing vascular compromise and neurological deficits. And they have this plexiform neurofibroma, they have a risk of malignant transformation, 10% risk of malignant transformation. So they can transform into this malignant peripheral nerve sheath tumors. And these MPNST can be sporadic as well as it can be associated with NF1. When they are associated with NF1, it can be multiple. And so how will you know that this plexiform neurofibroma is turning into a malignant lesion? So they'll show rapid growth, or they can be associated with severe pain, new neurological deficit, or a change in the texture to a solid form. So then we have to suspect that it is turning into a malignant lesion. So this is actually resistant to chemotherapy with a poor prognosis. The 5-year survival rate is only 20 to 50%. So coming to the ocular features of neurofibromatosis 1. So one is the Lisch nodules. That is, they are the hamartomatous lesions which are present on the anterior surface of the iris, and they are around, they are brown in color. And in Indians, it is difficult to see this. We'll have to do a slit lamp examination to find out this. And around 90% of the NF1 patients older than 20 years will have this lesion. And then they can have choroidal abnormalities like this choroidal bright patchy nodules. These are also difficult to see on a normal fundus examination. Sometimes this near infrared reflectance images have to be taken to see visualize these lesions. And in the eye, glaucoma can also be there. And different type of skeletal anomalies can also be seen, like generalized body changes like osteopenia, short stature, macrocephaly, and these neurofibromatosis patients, they have an increased risk of getting fractures. And focal bony abnormalities include tibial dysplasia or pseudoarthrosis, sphenoid wing dysplasia, scoliosis, non-ossifying fibrosis, pectus deformities of the chest, and occipital bone defects can be there. So let's see the sphenoid wing dysplasia. So they can present with asymmetric orbit and sometimes proptosis, sometimes inophthalmos. And since the bone is absent, the temporal lobe can sometimes herniate, thus causing pulsatile proptosis. And it is usually associated with the orbital neurofibroma as well. And in the image, we can see here the sphenoid wing is absent. So this is known as, so the orbit is not complete. So it is known as bare orbit sign. So then they can have this gliomas, which are low-grade glial neoplasm, and it is commonly seen in children. 15 to 20% of the children can have this glioma, and the common site is one is optic nerve, optic chiasm, optic tract, optic radiations, and sometimes it can involve the hypothalamus. When the hypothalamus is involved, they can present with precocious puberty. And so normally the child will not say any symptoms when we uh, screen. We will say that we will usually see that the child is having reduced visual acuity. And so this is a very slow growing tumor, and it can rarely spontaneously resolve also. So if it is affecting the vision, if there is a progressive reduction in vision, or when we do the serial MRI, there is progressive growth, then we have to intervene with chemotherapeutic agents. Then there can be focal areas of signal hyperintensities in MRI. They are usually benign, and 60 to 80% of the pediatric patients with NF1 have these lesions. And the typical sites are the brainstem, the basal ganglia, thalami, and cerebellum, and they are non-enhancing lesions. This is basically the myelin edema, and they will wax and wane throughout the childhood. And then coming to vascular complications, congenital heart disease, pulmonary stenosis can be there in 50% of the cases, and other vascular abnormalities also, like renal artery stenosis, cerebral artery stenosis, the Moya-Moya syndrome, as we can see here, aneurysmal lesions and AV malformations. And so there is an increased risk of stroke in NF1 patients. And also they have a lifetime increased risk of malignancy, pheochromocytomas, just leukemia, brain tumors, and breast cancer can be there. And also these patients can present with different neurocognitive and behavioral deficits, like learning disability in around 30 to 70% of the patients, ADHD in 50%, and also there is an increased autism prevalence in these patients. So coming to the diagnostic criteria, we have the National Institute of Health Neurofibromatosis type 1 diagnostic criteria. So in this, 2 out of 7 clinical features should be there. So one is like café spots. It should be 6 or more in number. And in pre-pubertal children, it should be 5 millimeter. And in post-pubertal individuals, the size should be 15 mm. And second is axillary or inguinal freckling. Then neurofibromas, 2 or more neurofibromas or one taxiform neurofibroma. Optic pathway glioma, 2 or more iris leash nodules, or 2 or more choroidal abnormalities, sphenoid dysplasia, androlateral bowing of the tibia, or pseudoarthrosis of long bone. Then the mutation, heterozygous pathogenic NF1 variant mutation. So 2 out of the 7 can diagnose this condition. Coming to management, so signs and symptoms develop over time. So longitudinal monitoring should be there. Genetic counseling should be done. And throughout childhood, annual skin examinations, skeletal growth, blood pressure, neurocognitive development should be assessed. And this ophthalmological examination, it is recommended annually till 8 years of age. And after 8 years, till 18 years, every 2 years, we have to do ophthalmological examination. For NF1 associated low-grade glioma requiring treatment, the chemotherapy is carboplatin-based chemotherapy, and often in conjunction with vincristine. And now ongoing trials are going on for MEK and mTOR inhibitors as well for NF1. So this optic pathway glioma, if it is affecting vision, or seriously it is growing, then chemotherapy can be given. And after chemotherapy, 1/3 of the children will regain some vision, and usually vision will remain stable or may improve post-treatment. And life expectancy, because of the risk of malignancy, the average lifespan is reduced by 10 to 15 years. And there is a 5-fold increase overall cancer risk, and more than 2,000-fold increase of neurogenic malignancies in NF1. So this next is a Legius syndrome. In this Legius syndrome, child will look like an NF1. In the sense, the child will have typical cafe au lait spots and the freckling, but other features are absent. So it can sometimes fulfill the NIH diagnostic criteria of NF1, and is caused by heterozygous germline mutation in SPRED1 gene in chromosome 50. And so this is also a tumor suppressor protein, and this Legius syndrome also comes under the rasopathy, and the inheritance is autosomal dominant. So clinical features, cafe ole spot and axillary inguinal freckling can be there along with macrocephaly in Legius syndrome. Other features of neurofibromatosis are absent. And along with this will have a Noonan type of a facial dysmorphism, like hypertelorism with downslanting palpebral fissures and low set ears. And the children will have usually neurodevelopmental issues, and rare chance of malignancy is also there. So in post-pubertal individuals with cafe ole spots, but still no neurofibroma or Lesch nodule, and NF1 phenotype is still unclear, then we have to do the genetic testing, maybe this Legius syndrome. So coming to neurofibromatosis 2, it is again autosomal dominant, and prevalence is around 1 in 33,000. And this NF2 gene encodes Merlin. It is also known as schwannomin, again a tumor suppressor and again a rasopathy, and it is in chromosome 22q. And coming to the diagnostic criteria, so we can diagnose NF2 if bilateral vestibular schwannomas are seen, or this NF2 pathogenic variant is seen in 2 different tumors, then we can diagnose NF2. If this is not there, then we have to see the major criteria and the minor criteria. So the major criteria is only one unilateral vestibular schwannoma, or this schwannomatosis in first degree relative, or 2 or more meningiomas, or the NF2 pathogenic variant in an unaffected tissue. If there are 2 major criteria, then we can diagnose NF2. Minor criteria is more than one of ependymoma or meningioma, or like juvenile subcapsular or cortical cataract, retinal hamartoma, or epiretinal membrane. We'll see all this. So if there is 1 major and 2 minor also, we can diagnose NF2. So in the skin, it is kind of an atypical type of a cafe ole spot, and the number of lesions are also very less than 6 usually, and these are like plaque-like placed intracutaneous hyperpigmented areas with occasional hypertrichosis, and sometimes subcutaneous nodular palpable lesions are also seen. And the vestibular schwannoma, which is a benign tumor and is a hallmark of NF2. So they arise from the internal auditory canal, and they go into the cerebellopontine angle, and usually presents with sensorineural hearing loss, tinnitus, vertigo, brainstem compression, and it is slowly growing. The growth rate is around 1 millimeter per year. And the next most commonly involved nerves would be oculomotor and trigeminal nerves. Then the next tumor, 50% of the individuals have meningioma, and the common site will be convexity, skull base, falls, and around the optic nerve. So in this MRI, we can see, so the optic nerve is preserved, but from the meninges, the meningioma is there. So in the post-contrast image, this looks like a tram track. So it is like a tram track site. They have variable growth rate, and sometimes if it is present with brain edema, then it needs surgical intervention. Coming to the spinal cord tumors, in NF2 we have different types of spinal cord tumors, around in 70% of the cases. So it can be spinal schwannomas, extramedullary meningiomas, intramedullary ependymomas. And so depending on the location, we can get different neurological deficits. So this intramedullary ependymoma is seen in around 33 to 53% of the patients. And the common site, as we can see here, is like cervicomedullary junction or in the cervical cord. So sometimes it can span to involve different vertebral levels. Then it is known as string of pearl site, when multiple ependymomas involved span over different vertebral levels. And then, so when we see here how to diagnose is like, this will be a T1 isoindence and T2 hyperindence lesion, and it will be mostly homogeneously enhancing in MRI, and mostly it will have a cystic component. And it is usually indolent and asymptomatic, and they generally do not require any intervention. And 50% of the patients can have polyneuropathy. It is mostly axonal more than demyelinating. And sometimes children can have this mononeuropathy also, mostly affecting facial nerve. And coming to the eyes, sublendicular opacities, as we can see here, cataract can be there. Then epiretinal membranes, then retinal hamartomas can be seen in NF2. That is this grayish white lesion which we see in fundus examination. And then optic disc gliomas and optic nerve sheath meningiomas can be seen. And sometimes a patient can present with unexplained amblyopia or strabismus. So management is by multidisciplinary team, and a high rate of mosaicism is seen. So sometimes this mutation will only be present in the tumor. So if the genetic testing is negative in blood, to diagnose, we may have to take sample from the tissue. And so traditional treatment, surgical removal of the tumors, and now bevacizumab has also been tried. Coming to schwannomatosis, so this has significant overlap with NF2. So it is considered as the third form of neurofibromatosis, and the mutation is SMARCB1 gene mutation, which is present in 50% of the familial schwannomatosis cases and 10% of the sporadic cases. And sometimes it may be due to this LZTR1 gene mutation as well. So in this, you get multiple schwannomas, nerve schwannomas at different sites. And so the patient usually presents with pain and neurological deficit due to the nerve involved. And so here the difference is that they never develop vestibular schwannomas. So that is how you differentiate from NF2. So coming to the next syndrome, that is sclerosis. So this is again autosomal dominant, and the prevalence is 1 in 6,000 individuals. And so we get different hamartomatous lesions that primarily affect the brain, skin, heart, eyes, kidneys, and lungs. And 70% of the TSC cases occur sporadically, and the remaining cases are familial. And so there are two genes are there. Both are tumor suppressor genes. Both are rasopathies. The TSC1 gene is located in chromosome 9q34, and that encodes for hamartin. And TSC2 gene is located in chromosome 16p13, and it encodes for tuberin. And so both of them downregulate the mTOR pathway. And TSC1 more often is familial and has a milder phenotype, and TSC2 mutations are sporadic and they present with more severe clinical phenotype. So diagnostic criteria, if TSC1 or TSC2 pathogenic mutation is there, we can straight diagnose it. Or the clinical criteria, that is definite means 2 major or 1 major plus 2 minor, possible is 1 major or 2 minor. So we'll see the major criteria. It involves hypomelanotic macules. We'll see all these. At least we require 3, at least 5 mm in diameter. Then 3 angiofibromas, 2 ungual fibromas, then Sjogren patch, multiple retinal hamartomas, cortical dysplasia, subependymal nodules, SEGA, cardiac rhabdomyoma, lymphangioliomyomatosis, and angiomyolipoma, at least 2. And the minor criteria include confetti skin lesions, dental enamel pets, intraoral fibromas, retinal achromic patch, multiple renal cyst, and non-renal hamartomas. So these are the major criteria. These are the hypomelanotic macules, which are seen in birth or infancy itself and is present in 90% of the patients. And then these are the facial angiofibroma, also known as adenoma sebaceum, seen in 75% of the cases, and the age of onset is around 2 to 5 years. And then we have the Sjogren patch, which is seen in the lumbosacral area. It is seen in the first decade in 50% of the patients. And so this has a orange peel type of an orange peel surface, or very irregular surface. Then the ungual fibromas, which are small growth, which grow from the nail bed into the nails. And this is seen mainly in adults, in 20% of the adults. And then there are confetti lesions, which are multiple hypopigmented lesions scattered over the arms and legs, seen in 3% of the children, up to 58% in adults. And then in the teeth, we get the enamel pits, as we can see here, and also the intraoral fibroma, which is usually seen from the gums, but it can also be from the lips or from the tongue or even from the buccal mucosa. And this is also seen in adults. Coming to the ophthalmological features, in tuberous sclerosis, we see multiple retinal hamartomas like the NF2. And also we can see retinal achromic patch, that is areas of hypopigmentation seen in the retina on fundus examination. And CNS manifestation, though, so these patients mostly present with epilepsy, autism, or neurodevelopmental delay. And so in the imaging, the three main findings we have to look for will be the tubers, the subependymal nodules, and the SEGA, that is subependymal giant cell astrocytoma. So the tubers are mainly congenital cortical dysplasia caused by failure of the neuronal migration during fetal development. And the tubers are found in 90% of the patients. And so they are basically T2 hyperintense lesions which are seen. And they have a cerebral white matter radial glial migration line, as we can see here. If that is associated, it is basically, we can diagnose tuberous sclerosis. And then subependymal nodules, these are also benign lesions from the ependymal lining of the lateral ventricles, and it is also seen in 90% of the individuals. And they can be detected in utero also, and are often present at birth. And these subependymal nodules, they do not enhance on contrast, and mostly over time they will calcify. And so this appearance is known as candle dripping appearance in MRI. Coming to SEGA, which is the subependymal giant cell astrocytoma. So average age of onset for SEGA will be 11 years, and rarely after 20 to 25 years also it can happen. So these are benign lesions, but the problem is that they are located near the foramen of Monro. So because of the location, they can cause obstructive hydrocephalus when they grow. So the patients can present with features of acute presentation with features of raised ICP, and it can often be life-threatening. And the size will be 5 to 10 mm with a progressive growth of around 2 to 5 mm per year. And so if intolerant, serial monitoring every 1 to 3 years should be done. And so if it is problematic, surgical intervention with gross total resection can be curative. And mTOR inhibitors, that is mainly everolimus, for asymptomatic growing SEGA, we can give mTOR inhibitors, that is everolimus, can be given. So epilepsy is found in 80% of the patients with multiple seizure types. And so 50% of the infants will present with infantile spasms. And then later they can develop refractory epilepsy and Legius phenotype. And so poor outcomes are correlated with infantile spasms, early onset epilepsy, and refractory epilepsy. And the treatment options include anticonvulsants, of which vigabatrin is preferred. First line anti-seizure medication in infantile spasms, and also ketogenic, in refractory cases, ketogenic diet, vagus nerve stimulation, and epilepsy surgery. And then the tuberous sclerosis is associated with neuropsychiatric disorder, that is TANT. So autism spectrum disorder is seen in around 50% of the patients, and intellectual disability with developmental delay is seen in more than 50% of the cases, and ADHD also. And also they will present with this psychiatric symptoms, behavioral symptoms like aggression, temper tantrums, sleep disturbance, and self-injury can be there. Depression and anxiety can be there. Cardiac rhabdomyoma, which is again a benign lesion hamartoma. And in TSC, multiple rhabdomyomas are seen. So they're usually asymptomatic, but depending on the location, they can be symptomatic also, causing outflow obstruction. Then if it is in the conduction pathway, it can present with different arrhythmias, and then it can also present with failure, heart failure. And usually it is mostly symptomatic in the infancy period, and they usually regress after first year. Coming to recent manifestations, angiomyolipoma, again a benign lesion, is seen in around 50 to 90% of the cases. So just like the name, it contains a abnormal vasculature, the smooth muscle component, and adipocytes. And so usually benign lesion, they may be asymptomatic, but the problem is because of the abnormal vasculature, they can present with sudden retroperitoneal hemorrhage, which can be life-threatening. And the patient can present with flank pain with hematuria. And so next is like multiple renal cysts can be there. So when this is involving the adjacent PKD1 gene especially, the patient can present with multiple cysts. And then there is a risk of renal cell carcinoma, that is in the early age, 2 to 4% risk is there. Coming to lymphangioliomyomatosis, so that is a abnormal proliferation of the smooth muscle cells in the lungs. So this is seen in females affected with it can come as sporadic also. And it is very rare in males. So this is a low-grade neoplasm, but they have a metastatic and a malignant potential. So the patient can present with hemolysis, recurrent pneumothorax, and thyrorax. Ascites, lymphatic tumors. It is, but if untreated, it can lead to respiratory failure and it can be fatal also. So coming to the evaluation and management, so this is again genetic counseling is required, multidisciplinary with annual skin examination. So MRI, if there is SEGA, MRI has to be done annually or every 3 years in patients younger than 25 years of age who are asymptomatic. And so we have to annually screen for development delays and autism with the TANT checklist. And if the SEGA is symptomatic, then acute resection or VP shunting has to be done. And if it is asymptomatic but enlarging, mTOR inhibitors can be given. An annual echocardiogram should be done. Annual ECG should be taken to look for any conduction abnormalities. And in the kidneys also, MRI of the abdomen has to be done annually, assess the renal function and BP annually. And for angiomyolipoma also, if it is asymptomatic, mTOR inhibitors can be given. And if it is symptomatic, like it can present with sudden retroperitoneal hemorrhage. So that is treated by embolization followed by corticosteroids. And in the eyes, annual examination has to be done. And also lungs, if asymptomatic individuals, HRCT has to be repeated every 5 to 10 years. Otherwise, pulmonary function should be done every 2 to 3 years. MRI every 1 to 3 years. Angiomyolipoma. HRCT to be done every 5 to 10 years to screen. That they've mentioned HRCT only on the screen. Coming to the next syndrome, that is Sturge-Weber syndrome, which is a vascular malformation syndrome affecting the skin, brain, and eyes. So prevalence is 1 in 20,000 births, and the mutation, it is in GNAQ gene mutation in chromosome 9q21. So here there is abnormal leptomeningeal vascular malformation in the brain, which is mostly affecting the parieto-occipital region, usually unilateral, but it can be bilateral also. And then the typical port wine stain is there. So this abnormal vascular malformation is ipsilateral to the port wine stain. And so because of this abnormal vessels, it can cause chronic ischemia to the brain parenchyma. So it will lead on to neuronal loss and later calcification of the area. The mutation, the blood. The mutation is somatic mosaic mutation. So we may not find it in the blood. So coming to skin and eyes, so this is a typical port wine stain. It is difficult to identify if the patient is dark skin. And so it usually will be in the ophthalmic branch area of the trigeminal nerve. And if the forehead and the upper eyelid is affected, there is a 10 to 35% chance of the brain getting involved. And if the eyelid is affected, 50% chance of glaucoma is there. And the glaucoma, 2 peaks are there, can be seen in infancy or young adulthood. So screening should be done. And if there is glaucoma, the patient can have ophthalmos, megalocornea, and that is increased size of the globe can be there with conjunctival ingestion and excessive tearing from the eye. And 80% of these individuals can present with epilepsy and focal seizures with or without evolution to bilateral involvement but other forms like infantile spasms, atonic absence seizures can also be there. Then the patients, because of these abnormal vessels, they can present with stroke-like episodes. That is mainly hemiplegia, and the visual field cuts will be there. But in infants, it is usually seen in infants and toddlers, and they also have seizures. So it is difficult to identify whether it is a TOTS paralysis or hemiplegia. And then headache with migrainous features can also be there. Then the patients can have neurodevelopment delay with intellectual disability. So to diagnose, uh, this gyral calcifications can be seen as like serpentine pattern or a railroad track pattern. This can be seen in CT, plain CT, or even skull X-ray. And this in the MRI, we have to look for the parenchymal changes. That is a focal atrophy. And then in the contrast MRI, post-contrast even, we have to look for the abnormal leptomeningeal enhancement. We have to look for these abnormal vessels, which can be seen here. And so coming to evaluation, so epilepsy, anticonvulsants should be given. And in refractory cases, vagus nerve stimulation and ketogenic or Atkins diet to be followed. And hemispherectomy, especially if there is a pre-existing hemiparesis or visual field cut, we can go for hemispherectomy in case of refractory epilepsy. And then because of the stroke-like episodes, low dose aspirin should be given. The dose is 3 to 5 milligram per kg per day. And then we have to screen from birth onwards. We have to, every few months, we have to screen for glaucoma, and lifelong annual eye examination should be done. Then for the pot point stain, laser treatment can be done. And clinically, this genetic mutation, generally clinical testing is usually not indicated because it may be negative. Then coming to the next one, that is Incontinentia pigmenti. So this is a X-linked dominant condition. So it is very lethal for the male children may not survive. So mainly it is affecting the females, and it is caused by the mutation in IKBKG gene, which is also known as a Nemo gene, in the chromosome XQ28, where there is a deletion of exon 4 to exon 10. And so this will activate nuclear factor kappa B, which will activate the inflammatory immune and cellular apoptotic pathways, which are responsible for all the findings. So we have a major criteria and a minor criteria. So in the major criteria, we have to look for the typical lesions which are along the Blaschko's line. So the lesions will have a vesiculobulla stage, a verruca stage. Vesiculobulla stage, it is usually seen in the first few months of infancy itself, where there will be vesicular lesions along the lines of Blaschko. And then it will turn into the verruca stage, which are raised papular lesions. And then it will turn on to hyperpigmented stage, which are like hyperpigmented macules. And then later in the early childhood, they will go into the early atrophic or the hyperpigmented stage. So this is a verruca blister-like stage, and this is a hyperpigmented stage. Coming to minor criteria, dental anomalies can be there. That is hypodontia or delayed tooth eruption can be seen. Ocular anomalies, it is mainly retinal detachment can be seen. Then CNS we will see later. Then the patient can have alopecia, especially in the vertex area, and also hair abnormalities, alopecia, nail abnormalities, palatal abnormalities, and nipple and breast abnormalities can be seen. Sometimes multiple nipples can be seen. Sometimes hypoplasia can be seen, and history of multiple male miscarriages in mother, and typical skin histopathological findings. So these are the minor criteria. And if there is no evidence of incontinentia pigmenti in a first degree relative, or no mutation, genetic mutation is available, then two major or one major plus one minor can diagnose this condition. If there is a mutation or a family history, then one major criterion or two minor is enough. So coming to the CNS manifestations, so 30% of these individuals have the significant morbidity. They can present during neonatal or infancy period itself. Because of the inflammation, there can be micro occlusion in the vessels. causing stroke-like episodes, which is affecting the deep and subcortical white matter, or it can even affect large vascular territories like MC and ACA territory can be involved. And this can later go into hemorrhagic change, and then cerebral dysgenesis can be seen. That is cerebellar hypoplasia, cerebral atrophy, corpus callosum hypoplasia, and 20 to 40% of the patients can present with epilepsy. And in infancy, patient can present with an Adam kind of a presentation also in Incontinentia pigmenti. And management. Genetic confirmation with targeted mutation analysis in early infancy, we have to do. Then multidisciplinary approach for different involvement, and monitoring of visual complications have to be done. Then if the child is having epilepsy or neurological deficit, MRI with MR angiogram needs to be done. And in case of severe ophthalmological complications like retinal detachment, laser photocoagulation option is available. And the dermatological condition which presents in infancy, they do not require any treatment. So coming to the next one, that is hypomelanosis of Ito. This affects the skin, brain, eye, skeleton. And this is a sporadic disorder with minimal recurrence risk, and multiple mutations can be seen. Mainly chromosomal anomalies in ring chromosome 22, mosaic trisomy, etc. And so here also the lesions are along the lines of Blaschko with hypopigmented whorl streaks and patches which are seen during the infancy period. So in the other case, it was hyperpigmented lesions. So here, these are like hypopigmented lesions in the infancy. And so it can be unilateral or it can even be bilateral. Sometimes it is very difficult to identify. Wood slam examination has to be done. And in the CNS, 50 to 90% of the patients can present with seizures, macrocephaly. Then cerebral or cerebellar hypoplasia is the most common abnormality. And sometimes these patients can present with hemimegalencephaly also, and also lissencephaly and other cortical neuronal migration anomalies. And so this hemimegalencephaly may be ipsilateral or contralateral to the cutaneous hypopigmentation. Coming to the ophthalmological feature, the patients, around 50% of the patients have this microphthalmia, heterochromia iridis, dacrostenosis, pannus, corneal opacities, cataract, and pigmentation anomalies of the retina. And so, the patients can also have hemihypertrophy and multiple skeleton anomalies. Also, finger changes like clinodactyly and polysyndactyly can be seen. Dental anomalies can be seen. Cardiac defects, including TOF, pulmonary stenosis, and septal defects, can be seen. And disorders of endocrine and renal development can also occur infrequently. So coming to the next, that is von Hippel-Lindau disease. So this is again autosomal dominant. It is a rasopathy. The gene is VHL tumor suppressor gene located on 3p25. Incidence is around 1 in 36,000 people, and the median age of presentation here is late, 20 to 25 years. So coming to the neurological features, here we have to look for hemangioblastomas. That is the most common site is cerebellum, but it can also involve the brainstem as well as the spinal hemangioblastomas can be seen. So this is seen in around half of the patients. So depending on the site, they can present with different neurological deficit. And in the spinal cord, the most common site is conus medullaris or cervicomedullary junction for hemangioblastoma. So then the next is they can also have endolymphatic sac tumors in 10 to 15% of the cases. So in this MRA, the same patient is having retinal hemangioblastoma as well as cerebellar hemangioblastoma. So how to identify hemangioblastoma will be it will be T1 hypo to isoindents and T2 hyperindents. And the post-contrast image will show this enhancing mural nodule, but the cyst will not enhance. So this enhancing mural nodule can be seen. That is how we identify in MRI. So coming to ocular features, the retinal hemangioblastomas can be seen in 50% of the patients. They are usually asymptomatic, but sometimes can lead on to hemorrhage. So these are seen as like a reddish to pinkish lesion on fundus examination. And the patient also can have glaucoma, uveitis, macular edema. Coming to the systemic features, so renal cyst can be seen, RCC can be seen in around 70% of the patients. So this these patients, RCC is a leading cause of death in VHL patients, and 7 to 19% of the patients can have pheochromocytoma and also adenomas of the pancreas and epididymis. So there is a screening protocol, which is the Cambridge screening protocol, which is done in the patient as well as in the relative. First degree relatives should also get screened. So annual physical examination and urine testing should be done. Annual direct and indirect ophthalmoscopy and MRI or CT every 3 years till age 50 and every 5 years thereafter. Then annual renal ultrasound should be done every 3 years and abdominal CT every 3 years to look for different malignancies. And so annual 24-hour urine collection for VMA should also be there because the risk for pheochromocytoma. So coming to the next one, that is hereditary hemorrhagic telangiectasia. It is also known as Rendu-Osler-Weber syndrome. And so this is again autosomal dominant. So here, just like the name, there are telangiectasias affecting multiple sites, skin, mucous membrane, and various internal organs. And the prevalence is 1 in 10,000. And so here, the telangiectasia is because of the absence of elastic fibers and smooth muscles, thus causing this malformation. So there are 2 genes involved. One is in chromosome 9q33, that is a HHT1 gene, and which is coding for endoglin. And the other is HHT2 gene, which is in chromosome 12q, and that is coding for ACVRL1. And the criteria name is Kurashio's diagnostic criteria. So if 3 criteria is present, then it is definite. If 2 is present, possible, and less than 2 is unlikely. So the criteria are, one is epistasis. It can be spontaneous or recurrent nosebleeds, and telangiectasias in the lips, oral. So we have to look in the lips, oral cavity, fingers, and nose. So here we can see telangiectasias of the fingers, and also the visceral lesions, that is mainly AV malformations involving the GIT, the hepatic, cerebral AV malformations, and spinal AV malformations, and a family history in the first degree related. So if 3 is present, we can definitely diagnose this. So CNS, the patient can present with headache, dizziness, seizures, and also because of the AV malformation, there is a risk for paradoxical embolism because of the pulmonary AV malformation. So these patients can present with stroke as well as intraparenchymal or subarachnoid hemorrhage. And the septic microemboli can pass through this pulmonary AV malformation, causing abscess. So there is a risk for brain abscess in these patients. And then this AV malformations, because of the AV malformations, the high flow pile fistula can be there, and cavernous malformations, venous angiomas, and also vein of Galen malformations can be seen in HHT. And screening so should be done with MRI with MR angiography every 5 years. So coming to the next, which is Noonan syndrome with multiple lenti genes. So this is again a rasopathy. The 3 different mutations can be seen with PTPN11 gene, which is being the most common mutation. So here we can see like multiple dark pigmented lesions, which are known as lenti genes in the skin. So they are present from birth itself, and it can increase with age. And then typical Noonan-like facies can be seen with hypertelorism and loss at ears. And the CNS involvement is mainly learning disabilities with seizures can also be seen. In the heart, hypertrophic cardiomyopathy with RBBB and pulmonary stenosis, sensory neural hearing loss can be seen, and multiple skeletal abnormalities can also be seen. And then the syndrome neuromelanosis. So here the patient can have from birth a large melanotic nevi can be seen. So this is known as bathing trunk site. That is mainly on the trunk it will be seen large. And in the brain they can have melanosis, which is involving the leptomeninges or sometimes the brain parenchyma. So in the brain parenchyma, this melanosis will be T1 hyperintense and T2 hypointense, and the main regions will be amygdala, pons, and cerebellum, and mainly the brainstem. And so here the patients have a high risk of CNS melanoma and death, and the mutation is NRAS mutation. And then the epidermal nevus syndrome. So these are the heterogeneous group of syndromes. And the most important and frequent anomaly in the brain is hemimegalencephaly. in this. So here, this is known as Heidi syndrome, in which it is a triad. That is, the patient will have this verrucous nevi in the one side of the face, along with ipsilateral hemifacial lipomatosis will be there. And along with that, that same side, hemimegalencephaly will be there. So the patient present with mainly intractable seizures and developmental delay. That is known as Heidi syndrome. So to summarize, there are a group of genetic disorders, and of which most common syndromes are NF1, NF2, tuberous sclerosis, Sturge-Weber, and von Hippel-Lindau. And so mainly CNS manifestations, patient present with epilepsy, development delay, and two different type of tumors. So they always require multidisciplinary approach, and the follow-up is also essential because lifelong risk is there, and so we have to follow these patients and do annual screening. Thank you. Because many of these patients have vascular malformation, there can be increased risk of bleed. We do vascular interventions.
Because they help with epilepsy patients. This is only the sickness.
Neurofibromatosis type 1
Cirrhosis.
that is mainly in SECA, which is asymptomatic but still growing. This everolimus has shown in trials benefit is there. But once the everolimus is stopped, they also have recurrent.
Patients with better spans or epilepsies, specifically found in the
Not sure. Does we
more than 6 years of age, the factory focal pathway better spans. More than 6 years of age. What is this Hippel-Lindau person?
That is hemihypertrophy will be.
Not the same gene, but transformation. And which will get presented for United States, along with centers, lessons. Other anything. All these patients are not very low, including the patients with Hypomelanosis. They're available to treatment with side of the sclerosis. The same applies to these patients. Will be another vascular complication. Simultaneous and proteins are good for you. It's very important you recognize these symptoms or initiate these therapies such as prevention.
I think Surabhi's presentation was very informative and very concise. It's a huge topic, and most important thing is regarding the diagnosis. It appears that if you have a neurological manifestations plus cutaneous manifestations, we can diagnose neurocutaneous cirrhosis. But many times we have got reference as demyelinating disorders when they have missed the cutaneous signs, especially in neurofibromatosis 1, they identify FASI, or in cases of cortical tubers in tuberous sclerosis because they miss the cutaneous manifestations. So this can occur, and so careful clinical examination and see for the dermatological findings. The second important thing is surveillance. There are recommendations which are available in NCBI gene reviews and other guidelines, how to follow and monitor for this various complications associated with the neurocutaneous syndromes. It is very hard to remember every time, so you can save it in your office laptops or systems where you can copy paste these recommendations. And the third thing, there are treatment as already suggested, like in case of neurofibromatosis 1, if you have plexiform neurofibromatosis, we have an recently approved therapy MEK inhibitor, selumetinib. If we can try in the plexiform neurofibromatosis, which is inoperable. And in mTOR inhibitors in tuberous sclerosis, especially in SECA and angiomyolipomas, other tumors, and also in refractory epilepsy. There are other treatment modalities that we have to consider is low dose aspirin in Sturge-Weber syndrome. And of course, managing this other complications. So the treatment, probably in the next presentations, we will have more treatment avenues with us for managing these kind of patients. So I will. Surveillance.
Right, of the plan. They are increasing in size.
Annually or some in if there is a progressive growth is there, like once in few months we have to take repeat MRI, and if progressively if it is growing, then intervention with the chemotherapy, that is basically carboplatin based chemotherapy should be good. So they have mentioned like this carboplatin based chemotherapy for that.
Radiation is not predicated. And transform iron mushrooms. They are exposed to radiation. It's not sure of these.
They have a high risk of.
Yes, patient.
Thank you. We are winding up the session.